Good evening, everyone. Today we'll be going through a topic that's relevant to those attempting OSCE this in October at Hyderabad. So every Friday we'll be bringing in topics that are relevant to emergency medicine, and as with every week, this week this is about OSCE. So OSCE, the full form is Objective Structured Clinical Examination. So in this, you will be tested on your clinical skills, how you approach the patient and how you do some procedure. So whether you're on par with the rest of the emergency physicians as per the standards or not, that will be evaluated. So during COVID, there was even a facility wherein some stations were physical, some were remote, wherein the examiner was watching you while you perform on a subject. So not all examiners could come to the venue. So if you have ever heard about step 2 CS of USMLE examination, this is almost similar to it. Here you will be tested on your both clinical and communication skills. Your patient could be both adult and pediatric. So one of the patients will be given to you. So based on the topic, that is the station topic, they will provide you with a subject, either a pediatric or adult subject. In case of pediatric population, you are expected to manage a seriously ill child or injured child, or in case of any other common childhood emergencies that you are supposed to be aware of. So coming to the structure of the examination. So you will have about 16 stations and plus 2 rest stations. So overall, you will have 18 stations. And based on the availability of infrastructure, be it the number of rooms or number of examiners, some might have at a stretch 18 stations with the rest stations including, or some of them might have 9 plus 9, like that they will split it. So either 2 circuits or 1 circuit with 18 stations. And in that, you will have 8 minutes per station and 1 minute in between each station. The rest stations sometimes might be 2, depending on who is conducting this. Some people might choose to give you 2 rest stations, and during mock examinations and all, some might prefer to give you 4 rest stations. So coming to the stations, you have about 16 stations. These are complex stable patients, that is specialty learning outcomes 1. From that, you will get about 3 OSCE stations. 2 stations will be answer questions, wherein you will be either teaching a student who will keep on asking questions. This can be sometimes included as part of SLO 9 too. So even SLO 9 is about supervise and teach. So these 4 stations, they can mix and match. And there are 2 research stations. These are very important. Out of these 2, you must score pass at least one of the stations. Even if you do rest of the stations well, and if you fail 2 research stations, your overall result will be a fail. Next, pediatric emergency medicine, you have 1 dedicated station for pediatrics. In procedure skills, you have 2 stations, complex challenging situations. In this, they will either give you a difficult referral or some situation wherein you have to confront your own colleague if they've done some mistake and all. So those things will be under complex challenging situations. So before you enter your room, there are some basic things that are expected from the OSCE performer, which are, so once you are at the station door, you will have a paper with question scenario. So you will have to read that question and understand the question within that 1 minute. And if you're done reading and understanding within 30 seconds, next 30 seconds, you can keep formulating your plan. So it's difficult within that 1 minute, but everyone has the same minute. So don't get stressed about that. So read and understand the pie chart. So for example, here I have given a pie chart which says history in the green zone and examination in the yellow zone. So if you keep on asking more history from the candidate, that means you have not read the pie chart well. So in that case, some examiners might give you a hint to actually ask you to go and look at the question scenario again. But not everyone is going to talk to you during the session. Some will be just observing what you're doing. If you're wasting your time with history taking, they may not prompt you, but some will ask you to go and look at the pie chart again. That means you're going away from where you're supposed to go. So instead of examining the patient, you're taking more history. In that case, they will prompt you. Again, it's not mandatory. So once you are done with those 8 minutes, if you have done bad, don't worry about that, because you still have more stations to outperform than the other candidates. So if you keep on thinking about the bad station, it will actually going to ruin the further stations. So no matter how much you think, you cannot actually change the last station's performance. So don't let it ruin the present and next stations. So gather, that is, once you read the question, if you have enough time, gather information what you're going to do within those 8 minutes. So if it's about history taking, what are all the things that are supposed to be asked? If it's an examination, try to recollect what should be examined, in which order. So once your 8 minutes starts, there will be a timer. So even if the door is open, before you enter the room, please knock the door and say, may I come in? So once you get into the examination, don't talk to the examiner. Just imagine that you don't have an examiner there. You have to keep talking to the subject, that is your patient. So introduce yourself, get their identification. So sometimes they might try to test you by keeping a wrong patient in the room. So if you don't introduce yourself and get to know their identification, that will be a blunder. And most of the people, even if there is a name on the door, sometimes we might forget by the time we enter into the station. So it's important that you know the identification of the patient. And if they seem uncomfortable, better to ask them for any chaperone. Like some of the patients will be uncomfortable talking to you alone. So in that case, you can ask, do you want any friend or family member to be with you during the examination? You can ask that. If they seem to be in pain, you can say, if you have any pain, I would like to offer a painkiller. Would you like me to? So that's how it is. And consent. Though if someone comes to you, it's an implied consent, but don't take it for granted. You have to ask before you do anything else. So if you're going to check their pulse, peripheral pulse, let them know. Whatever their name is, call that name and say, I'm going to check your radial pulse. For that, I'll have to take your hand into mine. So would that be okay? So that way, if you want to check the carotid pulse, I'll have to check your pulse on the neck. Would that be okay? So ask before doing anything, especially when it comes to touching it. So ever since COVID, this has become a norm. So even before that, it was supposed to be done, but at least now you should have had a habit of this. So hand wash and alcohol rub if it's provided inside the room, you can use it. So in the OSCE, there are multiple domains. They call it as domains. So these are the things that get tested. Your clinical reasoning and decision making in that particular case, your communication skills, be it with the patient himself or one of your colleagues, any conflict, if it's communication skills station, any difficult referral, in those things, communication skills are very important, or any breaking bad. Next domain that can be tested is history taking, or how you're gathering the information. Your practical examination skill, clinical examination skills. So sometimes they will ask you to examine a joint or examine their thyroid, and anything they can ask you. So your clinical examination skills will be tested in this domain. Practical or pinnacle skills. In this, they can check your how you're doing some procedures. So for example, ICD placements or suturing, simple suturing can be checked, placing some back slabs or Thomas cleanse. All these things come into this. Teaching skills. Most of the times people get tested on how you teach someone on doing an ABG, or if there is a patient of hyperkalemia, how you're going to teach your resident on taking care, teaching DKA management. So this domain is all about your teaching skills and organization and prioritization. So though there are individualized 7 domains that get tested for MRCM OSCE, each station can have multiple domains. So don't think that only one domain will be tested in one station. So they can add 1 to 4 domains per station. So you'll be tested on multiple levels and in multiple domains. So coming to the scoring part, so they will be scoring you on how well you are on the competency level, your knowledge, your number of errors you're doing, and whether you could finish the task within that 8 minutes or not. So based on that, they will score you from 0 to 4. 0 means well below the minimum competence or very poor level of skills. You have been doing frequent errors and you could not complete the task. And 4 will be given if your performance is well above the level of competence and your skill level is well above the level of knowledge, and you have done made no errors at all, and you could complete the task to high standard. So in that case, you will get 4. Anything in between, they'll be giving you 1, 2, or 3. So in some aspects, like if you could finish the task, even with the errors and all, you can be given 3 or 4, or even from 1 also they can give you. So task completed 1 to 4, all of them are given 1 to 4 scoring if you have finished the task. How well you have done, based on that, this will be given. So out of each, they will give you a scoring. So when it comes to some sample scoring sheet, if you see, this topic is about the trauma. So we have done this. We have tested 3 domains during our mock testing. So we have conducted mock testing recently, and in that we have tested students on trauma. So in that, we were expecting to test 3 domains. One is clinical reasoning and decision making, one is clinical knowledge, and the other is your team skills. So these 3 things we have been testing on. So in that, coming to clinical reasoning, whenever there is a trauma case, you will be obviously getting a pre-arrival notification, especially in the UK. So during that time, whether you call for backup, once the patient comes, backup in the sense you have to page the trauma team, that is trauma surgeons, anesthetists, or any other backup you will be requiring, calling the blood bank. So all these come into calling for backup. Next, whether you check the vitals or not, or you taking the history. So in ATLS, major history should not be taken in a full extent immediately. So first, you will just get to know the mechanism of injury and all that comes into this history. So whether you have attached oxygen if required, whether the monitoring is started or not, whether you choose to give fluids or blood or tranexamic acid, all these things come into your clinical reasoning and decision making. So whether you have followed your ATLS guidelines in order, locating the wound, doing EFAS to rule out any bleed and pneumothorax. So trauma series imaging and then TET globe, administration of TET globe. All these things will be under clinical knowledge. And coming to team skills or communication skills, in that, in the beginning itself, you should have checked whether your team is ATLS competent or not. So whether you have checked competence, whether you're given the necessary referrals like trauma unit, blood bank, and how good you're in discussing with the family. So the family, if it's available, whoever brings the victim should be actually notified on what's going on. So even that is tested in the communication. So this way, in this, we have tested 3 domains. So one is clinical reasoning and decision making, clinical knowledge. So in case of major trauma, activation of mass transfusion protocol is very important. You have to mention about that specifically. So if you say I'll order for blood, you will some people will give you only half the mark. But if you say I will activate mass transfusion protocol, they'll be more impressed. Next, coming to communication skills. Sorry, the headings are in reverse, but communication skills, politeness with your colleagues or team, checking the competence, referrals, discussion with family, and practical skills, how you're doing EFAS, whether you're checking the airways needs, like whether basic is enough or not, or if an advanced airway is required, surgical airway is required, those decisions, how well you're taking. If there is an ICD need, trauma splint need, whether you're exploring that or not, is also tested in this. So coming to another kind of session, that is history taking. In this, there is a 45-year-old male with a history of recurrent unilateral headaches presenting to the ED. You're supposed to take a detailed history and manage the patient. So in this, they have given 50% marks for history and 50% to your clinical knowledge. So how they will assess your clinical knowledge? Based on what kind of questions you ask during the history taking. So establish a good rapport with the patient. Then whenever you ask question, they should sound relevant. They shouldn't sound like you have mugged up all those sequence of questions and you're just shooting them at the patient. Coming to sample history, so ask their signs and symptoms. If they say pain, you have to elaborate on the pain. So what is the site onset? This Socrates you must be aware of already. So site onset, character, radiation, associated symptoms, timing, exacerbating or relieving factors, and severity. Allergies, medications, past medical history, last oral intake, events leading up to present illness or injury. So this is the sample history, and any relevant family history should also be taken. Social history, whether he smokes or takes any drugs or if there is any alcohol consumption, any recent travel history or any what are the living conditions. So all these things come in the history taking station. So when you are taking history, elaborate on the relevant questions only. Don't ask things just for the sake of asking. At the end of it, please thank the patient and try to summarize the findings. Again, this depends. Some examiners would prefer you to summarize your approach, and some they don't expect it. If it's a too complex case that requires a lot of history, they might excuse you. But you should be able to offer DDs and to finish establishing a proper diagnosis based on this. What other tests will you be requiring? Whether you need an ultrasound to establish or CT scan, or if it's any headache case, would you like to have some temporal artery biopsy? So all these things you should mention. If you think you have reached towards a proper diagnosis based on your encounter with the patient, you can even include a treatment plan. So if you see in this station, so we have given history taking 50%. In this, I've told you what to ask it. In clinical knowledge, you have to look at the red flags of head injury. So any vomiting, visual disturbances and all. So in your DDs, you have to suggest trigeminal neuralgia and suggest any other alternative medications like carbamazepine or gabapentin. And which specialty will you involve? A neurophysician. So immediately CT MRI may not be required as you have got a proper diagnosis here itself. So all these things are going to count. So coming to the examination part. So if they give you more marks for the examination, keep your verbal tasks to less. Means asking the history about his complaints and all, they take less scoring. So based on how much of pie chart is distributed, you have to approach your patients. Your sequence is important. In what sequence you are going. So inspection, percussion, palpation, and then auscultation, all these, you should follow your sequence. So in this, we have given examination of the abdomen. So in that, whether you are introducing yourself, checking the patient's ID, whether you're asking for consent, if there is a pain, whether you're going in the Socrates manner or not, any associated feature, how you're questioning the patient. During palpation and all, you are supposed to ask the patient to flex their hips. So whether you're doing that or not, they're going to check. Exposure, you should do a gradual full exposure. So examine the hands, neck, head, check for any scars. So when you're looking at the patient, you should be running a commentary. Like now I'm checking for any visual scars. And during palpation, you have to tell the patient that you'll be checking. And during that period, you have to ask them to actually flex their hips and look at their face for any wincing. So that indicates a tenderness. Keep telling the examiner that you're looking for the liver and spleen margins. And when you're doing, you're actually supposed to let the examiner know indirectly, not directly. So don't tell the examiner that now I'm checking for liver. So instead of that, tell the patient, now let me look at your liver if there is any enlargement or not. Like that, you have to communicate to the examiner indirectly. Throughout your session, you have to imagine that there is no examiner, but you should let them know what you're doing indirectly. So mention per rectal examination, even though you are not doing there in the examination of abdomen, you are supposed to mention per rectal examination. And communication. So you should keep on explaining all along what you're going to do. Don't give any surprises. Tell the patient. If the patient, if someone comes to you with pain abdomen, and if you're going to press on the abdomen, palpate, obviously the pain will increase. So tell them beforehand. Now I'll have to apply some pressure on the abdomen. It might give you some pain. Do let me know if it's too severe, I'll stop. So that way you have to talk to the patient. After DDs, explain if there is any need for ultrasound or ECG or X-rays or CT. So whatever you think is relevant in that case, you have to tell the patient. So coming to resuscitation stations. So as I told you before, out of 2 resuscitations, you must clear one of them. Otherwise, your overall result will be failure. So in the resus, you're supposed to go in ALS or ACLS, PALS or ATLS. So in the same manner, you're supposed to go. So your dosing of drugs should be correct. Your frequency, if you're giving any shock to the patient, that is defibrillation or any synchronized cardioversion, make sure your joules are correct. if you're performing a defibrillation, even if you're alone there with the patient, you have to imagine that there are more people around you and say clear, then only deliver the shot. Whether you're following a proper sequence during your resuscitation or not, they will see. So during ACLS, checking for reversible causes is very important. So make sure you check the reversible causes. And if it happens to be some kind of overdose or toxic situation, any toxin ingestion, you must consider an antidote like intralipid, or if you have any established exact antidote, you might use it during the resuscitation. Then only you will have a positive outcome. Otherwise, the ROSC will not be achieved. So they will look at your effective teamwork. So passing a resuscitation doesn't mean you must get an ROSC. So whether you get an ROSC or not, more than that ROSC, your approach is more important. So don't worry if you could not achieve ROSC. So sometimes you will just be 1 or 2 steps away from ROSC. So the examiner will understand. So your approach should be important. What kind of questions you are asking during history? During history, only when you are checking the reversible causes, at that point, ask for history. So again, just like ATLS, you have to check the staff competency. And most of the times in reversible causes, they might give you some medications. So the patient took this overdose or something else, or they might say the patient is a CKD patient, that is chronic kidney patient, who has missed 1 or 2 episodes of dialysis. That means they're trying to give you a hint that it could be a potassium overdose. That means potassium excess. So hyperkalemia. So how you will manage that? Unless you give calcium, they may not give you an ROSC. Again, calcium is not a one-time thing. As long as you have ECG changes, you can give multiple doses. Sometimes I've given 4 or 5 doses too. So the calcium, what you use is important. So if it's a calcium gluconate, it will have less calcium content compared to calcium chloride. So it all depends whether you're giving calcium chloride or calcium gluconate. Coming to pediatric emergency medicine. So in this, though we don't, in India, we don't generally concentrate on non-accidental injuries. This is very important in UK. So you must suspect any non-accidental injury. That's why you should always ask for any social worker if you're having any suspicion of non-accidental injury. So under clinical knowledge, if you see, after analgesia, it says rule out non-accidental injuries. So if they give you a limping child who can only crawl, and if there is a major fracture, in that case, you will have to suspect non-accidental injury, especially if it's a spiral kind of fracture, or if there is a burn wound where you won't normally expect. So those are all your pointers towards non-accidental injuries. So you must mention that so that the examiner will know that you know about non-accidental injury. So limping child, you will have to give a differential by the end of your examination. So if it's a febrile seizure case, your counseling, the parent will be very much anxious. So your counseling is going to be very important. So you have to assure that this is not going to last when the kid reaches as an adulthood. So in that case, how to prevent this? So all these pointers you are supposed to give for febrile seizures. So tell them to control the temperature always. So these pediatrics can actually mix resuscitation also in this. If it's a case of any fever with rash, whether you're considering sepsis pathway, that is giving an antibiotic or not, all those things will be tested. So coming to practical skills, in that they can test you on any practical skill that you should be aware as an AR physician. So suturing, thermosplint, back slab application, ICD placement, external pacing, Foley's catheter application. So these, I'm just giving you a very limited set of practical skills, but they can test you on many others. So during these skills, the basics is if it has to be done under aseptic conditions, you have to maintain that. For example, if it's a back slab, this is not a big deal. But if it's an ICD placement, so it will be important during that. If it's a central line kind of thing, again, you will need aseptic precautions. Suturing also, it needs aseptic precautions. Organized approach, how you close. If it's a case of suturing, you have to tell them when to come back. If the spot, what are the signs of infection? Or if there is no infection, when to come back for removal of sutures. So all those things will be important. So during the procedure, you have to explain and take the consent. So if it requires giving any local anesthetic, in that case, you must check the expiry. So during our mock testing, we have actually given a local anesthetic that has already expired. So that's a major blunder if you give any expired medication. So you must check for the local anesthetic expiry. And needle. So you'll be requiring 2 needles here. One to draw the anesthetic into the syringe, but don't use that same syringe to instill the local anesthetic into the wound area. So you have to use a fresh needle for that. So these are all basics, and you have to make sure there are no air bubbles. You have to make sure you draw for any blood so that you're not in an artery or vein before you instill. So these are all basics that you need to know, and you have to keep on talking. So when you're trying to check for any blood in the syringe, like withdrawing the needle at that point of time, when you're withdrawing the plunger, you have to keep on telling that now I'm checking if I'm in a blood vessel. So everything you should verbalize, but not directly at the examiner, just as if you're talking to the patient. So during procedures, it's always a good practice to talk to the patients, especially if they are not sedated. Communication. This is very difficult to clear. So even if you have cleared, by the time you come out of the station, you will not feel like you have cleared. So till you receive the result, you will not feel confident about the result. So if this happens to be your first station, don't worry about the performance. Imagine you have done it well and move on to other stations. If this station is your last station, you're lucky. So this, especially if it's a difficult referral, before you talk to the consultant. So in the scenario, they might tell you that your team junior doctor has come to you saying, I spoke to the surgeon. He's not willing to come for a surgery. He's asking us to stabilize. But the matter of fact is, the patient is losing blood inside and an urgent surgery is required. At that point, you're supposed to convince the surgeon to actually come and do the surgery. So in that case, you have to know the issue in full, why your junior has called, what is already explained to the surgeon, and what else need to be stressed upon, that you need to know. So if you think that your team has made any mistake and has given any half information and all, you can apologize. I think my team has missed to inform you that there is an active bleed going on inside. That's what you can say. So if there is something that can convince the surgeon, you can actually use those terms. You can be soft, but you have to be firm. Explain why you are insisting. So every 2 or 3 words after that, just try to tell him that you are calling in the best interest of the patient. So you can say, in the best interest of patient, it's better to do a surgery immediately to control the bleed instead of wasting your blood products continuously. So unless you stop the bleed inside, whatever you give from outside will not be of any use. So if mention any relevant guidelines. So if your ATLS or trauma protocol of your own hospital says that if there is any active bleed in the abdomen that needs to be opened immediately, let them know. As per this guidelines, we are supposed to take him to surgery. If the surgeon says, no, I'm not going to say come, you can say that you are going to escalate the issue to your consultant or to the hospital administration. So again, you will not be feeling confident after this station. So don't worry about the result. Your approach is going to matter. So any communication skills, they are difficult. Any psychiatry stations, again, they are difficult. So coming to next, supervise and teach. So in this, they're going to test your teaching skills and how much you know about the topic. So always start with asking your student what they already know. And every now and then, do you have any, ask them whether they have understood everything in what you said. And ask them if you need to repeat anything. Ask them if they have any questions. And at the end of it, to learn more about this issue, I would like you to visit these websites, or you can ask them to collect a particular textbook from you, or you can go to the library and read this particular textbook. So this way you have to offer more learning resources. So in this, your skills and knowledge will be tested, and your teaching skills will also be tested. In this case, if it's about a safe sedation practice. So in that, what are the indications for this and what are the contraindications before you start your sedation, whether you're checking for any difficult airway or ASA grading, all these things are important. And keep checking their understanding and how to reduce the risk, and post-procedure management, how to manage the patient at the end of your procedure. So OSCE is nothing new. So whatever you do during your routine day-to-day patient care, that's the same thing you're doing here. So if you overthink and overstress yourself, that's where you might fail in the particular station. Again, you're only failing that particular station. It's not the end result. So if at one particular station is bad, don't worry about that. Go with a fresh mind to the other station. So it all depends on how well you manage those 8 minutes. So sometimes you might know everything, but still you will not be able to succeed if you don't recollect all that matter in that 8 minutes. So OSCE is tricky, but not impossible to clear. So just do what you do regularly. And if you do have any more questions, you can actually reach me, whether it's an email or social media or mobile, WhatsApp, Telegram. I'm available on this. So, and a recorded session of this will be made available on the Facebook. So to know more about where to check the Facebook link and all, you can actually get notified about those links on our Telegram channel, that is telegram.me/med_meet. So we'll be posting a recorded session link over there. please subscribe to this channel for that. If you have any questions, you can shoot over the Telegram app, or you can ask now also. There is one question, that is the course face-to-face or online? Now it's fully face-to-face. During COVID, 50% was online, 50% was face-to-face, wherein there is no need for any physical examination, and all those stations were made online at that time. But now every session is face-to-face. Nothing is online now. Okay, if you don't have any questions, then we'll be closing the meet. Thank you very much for joining us.